And welcome everybody to today's webinar on behalf of the American Journal of Bioethics. This month's webinar will focus on ethical issues raised by the uses of artificial intelligence in medicine. My name is David Magnus. I'm from the Stanford Center for Biomedical Ethics. Please use your Q&A to ask questions and to upvote questions for others that you would like to see asked. The potential for AI in medicine is obviously tremendous. Electronic health records, insurance claims, mobile and wearable health information, and even genome sequences are all vast amounts of data that are ripe for analysis using algorithms and models that allow for deep learning. Whether it's analyzing, detecting abnormal cell growth in chest radiographs, or using predictive analytics to stratify which patients are at greatest risk of developing sepsis, AI has been shown to be a potentially valuable tool and sometimes more accurate than physicians in making diagnoses and prognoses. But there are many concerns that have been raised about the uses of AI in medicine. In medicine, as in other fields, there are numerous sources of bias that can lead models to make recommendations that are systematically biased or discriminate against Black people, poor people, or others. Some of this can be due to limited data from some populations in the training set. Sometimes it can be caused by the ways that biases or inequalities can be embedded in the data itself. Some worry that AI will replace physicians, while others see AI as offering an additional set of tools to help physicians and empower patients. AI is currently being used to help make logistical and resource allocations for dealing with the pandemic. Like most technologies that are designed for use in medicine, there's a development pipeline that runs from conception to research to implementation. This month's issue of the American Journal of Bioethics features a target article that discusses the ethical and regulatory issues that arise along this pipeline. We are fortunate today to have four outstanding experts on these topics. First, Danton Char MD is an assistant professor in the Department of Anesthesia, Perioperative and Pain Medicine at Stanford University School of Medicine, and a pediatric cardiac anesthesiologist at Lucile Packard Children's Hospital. His research focuses on ethical issues arising in the care of critically ill neonates, infants, and children, particularly children with congenital cardiac disease. His long-term goal is to continue to identify and address ethical concerns associated with the implementation of next-generation technologies to bedside clinical care, like whole genome sequencing, and its attendant technologies like machine learning. He is the first author on the target article that we were discussing and that we will be talking about. Danton's co-author on this month's target article is Michael Abramoff, MD PhD, and fellow of the Institute of Electrical and Electronics Engineering. He's a practicing retina specialist, neuroscientist, and computer engineer. He's the Watsky Professor of Ophthalmology at the University of Iowa with joint appointments in the College of Engineering. He's also founder and executive chairman of Digital Diagnostics, the AI diagnostics company that was the first in any field of medicine to get FDA clearance for an autonomous AI. Author of over 300 peer-reviewed publications, he's been cited over 34,000 times and is a mentor on 17 issued patents. His lifetime goal is to increase healthcare access and decrease health inequalities through autonomous AI by lowering costs and improving productivity and quality. Michelle Mello, JD PhD, is professor of law at Stanford Law School and professor of medicine at Stanford University School of Medicine, where she conducts empirical research into issues at the intersection of law, ethics, and health policy. She is the author of more than 200 articles on medical liability, public health law, the public health response to COVID-19, pharmaceuticals and vaccines, biomedical research ethics and governance, health information privacy, and many other topics. She holds a JD from the Yale School of Law and PhD in health policy and administration from the University of North Carolina at Chapel Hill. Last but not least, Niranjan S. Karnik MD PhD is the Cynthia Wittijans Paris MD Professor of Psychiatry and Behavioral Sciences and Associate Dean for Community Behavioral Health at Rush Medical College and a conjoint faculty appointment in the Department of Community Systems and Mental Health Nursing at the Rush College of Nursing. He also serves as director of the Great Lakes Node of the National Drug Abuse Treatment Clinical Trials Network. His research focuses on technology and community-based interventions for high-risk populations with psychiatric and substance use disorders. Dr. Karnik wrote one of the open peer commentary articles this month, and he just pointed out that his co-author has just been named to the co-chair of the task force for dealing with the coronavirus that was just announced by President-elect Biden. Okay, let's go ahead and get started. So the first question I want to ask is really about exceptionalism. Does AI raise unique ethical challenges that differ from other issues in technology and its development that bioethics has always addressed? So is there anything new here? And could you each address the exceptionalism question? And I'll start with you, Dan.
Oh, okay. Well, thank you very much for having me, David. I think it's both. I think that there are both already existing concerns that are appearing in a new context with AI, but also potentially novel concerns. I do think what overall is most novel with AI, though, is scope. Unlike previous generations of medical technology that have been based on complex data, but where the interpretation of the output required a human to make a diagnosis or recommend some sort of action, I think that AI or machine learning tools now can generate conclusions or recommended actions. And I think that because of that additional step, these applications can encompass both all of the ethical concerns of complex statistical and computational tools, and also the ethical challenges that weigh in making a diagnosis or a clinical action. But I don't think that this novelty inherently means that we discard the prior. Certainly, John Luce and Bob Wachter of coronavirus tweeting fame nowadays wrote in the 90s about the problems, the ethical problems inherent with making bedside determinations from probability prognostics. And I don't think that that work can be completely discounted. I think it now applies, but there's also this additional step of the tool itself making recommendations.
Michelle?
Thanks, David. Well, I would second that. I think it's the predictive and potentially autonomous predictive nature of the technology that does raise some novel concerns. I think there's a second dimension, though, and that has to do with both the complexity and the opacity of the technology. I think when we're talking about other uses of electronic health data or other forms of technology that aid in diagnosis or even prediction, the underlying technology is a lot simpler to understand, and there are more people who can potentially understand it. With this technology, there is a certain degree of inability to see what's under the hood. And even if you could see under the hood, there's not many people around who know what they're looking at and can explain it, much less point out flaws with it.
Thanks very much. Michael?
Yeah, well, mostly I agree with the others, but you don't want to hear the agreement, you want to hear the disagreement. I think it's mostly a scalability issue. AI, as a physician, I think at most of your lifetime, you will maybe see 20 to 30,000 patients at most. We're talking about AIs that make medical decisions on, hopefully, if it goes where we hope it goes, to hundreds of millions of patients. So the impact of what you do in terms of bias or other problems that you have as an individual doctor that may average out over a group of doctors in a country is now exacerbated because there's only one AI or maybe a few competing AI. So I think the problems are bigger and the risks are bigger. But I think underlying, there was always bias in doctors. I think we moved from doctors who look at their local population and that's where they gain experience, to now where you gain experience maybe across the entire world in terms of the disease and how they manifest in people of, you know, since we're focusing on that, different races and ethnicities, that just didn't matter as much because you were trained and practicing in your local community rather than on this vast scale. So I think it's more a matter of scale, so quantity rather than quality.
Okay. Niranjan?
Well, David, I think maybe I'm going to take a little bit of a contrarian view here. I don't think the ethical issues are different. I actually think that the ethical issues and the questions that are going to be asked are going to be, you know, what we have asked for a long time. I see the issue being one of scale here, that there is a potential for rapid propagation of these dilemmas across, you know, vast geographies, and so that is where I see the potential problem, perhaps. I don't think the essential ethical questions have you know, fundamentally changed, and to some extent, I think researchers and scholars, especially in the social sciences, have been asking some of these questions for a very long time. I mean, I'm thinking right now, as you asked the question, I was thinking of Latour's book on Aramis, you know, and how he brings the train to life, you know, and technology is always sort of driving in this direction. And even if you look within science fiction, there, you know, a lot of these questions come up there. These dilemmas are I think, age old in some ways. But it is perhaps the scale that is different here.
Okay. The applications of AI in medicine seem to largely fall into predictive analytics that help stratify risk and make allocation decisions and diagnostic applications applied to pathological samples of radiological images. Do you all think the issues are similar, or do you think that these different types of applications, uses in pathology and in radiology, are fundamentally different from the sort of predictive analytics that are doing risk stratification? So do we need one ethics, a set of ethics principles fit all, or do we need two sets of principles? Let's see, why don't we start with, it looks to me like Niranjan wants to go first, so go ahead.
Well, I think the frameworks we might ask of these different approaches are a little bit different. And so I'm not sure that the ethics need to be different, but I think the frames through which we look at it might be. In our work, we're looking at certain ethical questions that come up at the very beginning of the development of the tools, but then throughout there's sort of an ecology of different questions, but they're all kind of interrelated in some ways. I mean, for us, in our team, we're very concerned about bias and representation within our samples and how to sustain that. So we ask permutations of that, but the tools that one uses to look at those different questions are different at each stage of the development. And I think that's what Danton and his colleagues kind of captured, was that pipeline model, right, in the paper. I think that was really a very solid part of it. But there is a whole lot around that sits outside of the space that is pretty complicated.
Okay. Any other thoughts of anybody else on this topic? I think, Michael, you might have had some thoughts about this issue.
Yeah, because I saw the question before. So I think you can look at this on a spectrum, a continuum of patient risk of harm, right? Where some do not lead to interventions, but just look at populations differently versus immediate action on a specific patient. I think, however, there's what you explained. What I see is there's parts that work on populations and define, you measure population health and differences, and the other on individual patients. And that's where the shift is, from more autonomy to the patient and more and less focus on the population as a whole versus the other one. So I think you can also split it into population health versus individual health. And that leads to maybe different emphasis on different ethical principles.
Michelle, do you have any thoughts about this?
I think it's a really interesting question. I'm honestly not sure about my answer, but I can foresee that the predictive end of things might be more ethically complex, because with the advent of computerized prediction, I think there's a risk of bringing a sort of false certainty to prognostication, where in the past we've been pretty candid about clinical uncertainty, that it is, human judgment and infected with all kinds of biases. I think there's a misguided risk of dismissing that there might be the same kinds of, or maybe different kinds, but same magnitude of biases or difficulties in computerized prediction. And so we may just get into a situation where the kinds of other normative considerations that have always guided clinical choices fall away a little bit more than they should, as we place greater faith than we should in the algorithm. Of course, anyone who has been a clinician knows that there are always going to be patient values coming into play alongside predictions about the success or failure rate of a treatment. And it's just a little unclear to me what that will look like as we increase in our faith in the ability of algorithms to predict clinical outcomes.
Okay. Can I respond to that, or?
Yeah, sure.
Because populations persons have values, and you can talk about an individual patient, and you can talk to them. To the population, it's impossible to speak, right, and have a discussion about what they want versus what can be done. And so I like you say, I think it's very different for populations versus individuals.
Also, David?
Yep.
I mean, I think part of the problem we're facing is that this question we're going to have to keep iteratively answering over the next number of years, because in many ways, the reason we're concerned about ethical problems emerging in healthcare is an extrapolation of ethical problems that have emerged in healthcare industries. And in many ways, what we were trying to do with the Target article, and I do think we as a bioethics community need to step forward, is we need a methodology, a conceptual methodology where we can call out ethical issues, hopefully in advance of them becoming demonstrable problems. And such a methodology needs to be useful because there are so many stakeholders affected, far in excess of the small cadre of bioethics experts who can weigh in, a methodology that's usable by all the people and interpretable by all the people who are potentially developing these things.
Well, so that actually raises an interesting question. So you've developed this framework that goes along this whole pipeline. Who is that ethical framework really primarily aimed at among those stakeholders? Is it primarily to the computer science developers, to the clinicians who are going to utilize it? Who is that framework supposed to really be applied to?
So it's a great question. Thank you. All. The answer is yes. All. I mean, I think it has what I was saying as its underlying conceptual idea, which is that we do need a comprehensive, or I think it's very hard at this stage in machine learning development to be comprehensive, but a methodological approach that can dovetail with randomized controlled trials, with implementation science, that can be an ethical mental map for how we think this through. But certainly our framework relies, the goal is only identification, not solving these problems, and it relies on a couple of premises, which not everybody necessarily agrees with, though I think many would. And the premises are that there are many stakeholders involved in the making and impacted by the making of these machine learning tools, that the stakeholders will have significantly different implicit and explicit goals for the machine learning tools and values. And then, as you mentioned, that the process of conceiving of one of these tools, designing and implementing it, moves through a series of decisions all the way through actually deploying it, how it subsequently gets used, and that how people would resolve these decisions or would want these decisions to be made reflects their underlying values. This is, we really drew on the work of like Kate Shilton, Johnson, Bray, Manders-Sweets, this idea that where stakeholder groups disagree about these decisions in design, where there are value conflicts, are most likely the fault lines where such ethical issues are likely to already, social issues, implementation issues, are going to emerge. And then as per your first question, I think it's both. We then resolve these questions drawing on, like Dr. Karnik was saying, already existing ethical, robust body of ethical literature, but also allowing for the possibility that there may be some novelty that begins to emerge in this. All right. That was my long-winded answer to your question.
But I think, David, I would point out one thing. I think I read the article, and maybe Dr. Char kind of can reflect on this. I read the article as really speaking to the current stakeholders, that are involved in the development of AI and its implications for healthcare. And I think one of the things to take away from the sociological literature and the ethics literature is that there are a lot of invisible stakeholders who don't have a seat at the table right now. They are impacted by these models. So it's not just the people in the pipeline at present that really should have a seat at the table. There is a lot of others who risk to be impacted and have been impacted already by various attempts to use AI in the healthcare space, and in those instances rather negatively. So I think that it's those invisible stakeholders that we have to A, lend visibility to, and B, develop a way to bring them into the conversation. And that was where we really pushed the structural disparities piece of that. Yeah.
Danton, you want to respond? You're on mute.
Sorry about that. I do think that we agree on that. I mean, I think that there is going to be a methodologic skill that has to emerge in identifying all of the stakeholders who are impacted or potentially impacted, and identifying them so that their voices and values can be heard. I think that's an important part of it. Our hope in centering the mental map of the process in this whole conception, design, development, and then further implementation and uses was to try and identify everyone who could have downstream contact or be downstream influenced by it. But you're right that such a model as we're putting forward, in the same way that the Romans didn't use randomized controlled trials, it's going to have to be iteratively revised as we get more experience with these algorithms. I mean, I also think that what you're touching on is really important in that the clinical application of machine learning and AI to clinical medicine is probably only a very small component of actually the way in which AI is going to impact medicine. I think the financial elements and the movement and allocation of material supplies are going to be a vast part of it. And I think you're absolutely right that the majority of the stakeholders impacted by those AI applications are invisible, even if they're quite prominent in other AI applications.
Thanks. Michelle or Michael, do you want to add anything to that? Or?
Well, if I might, I'd like to put a question to Danton, which is, I would love to hear more about your vision for how this conceptual framework gets operationalized, particularly in the development stage. I guess my informal observation of companies, at least large companies that are developing these technologies, is that they are well-intentioned and seek external advice from the ethics community. But at the end of the day, they take it back to their teams and they make their own design decisions based on a constellation of factors. Is that the right approach for, do we need to just give them this lattice of ethical problems and say, here's what you need to be thinking about and getting consultation about? Or is there something else that you envision at the development stage to make sure that not only are they aware of the ethical problems, but they resolve them in a way that's consonant with what other stakeholders would like to see?
This is going to start sounding like intellectual Wimbledon, because I can't pretend to have your regulatory or legal expertise on what is needed. But certainly, at our vision, the idea was having a tool that people could use to map out and in advance or early on in pilot deployment, identify where significant ethical, social implications, issues are emerging, and potentially formulate ways to address those. Not unlike, and we're not the first people to come up with this, not unlike in the way that there are multiple phase trials for drug development as well. And so the hope was, and that we as a bioethics community could begin to contribute to this. The hope was that there was a usable, intelligible mental map so that someone could dovetail with their other analyses to look at potential ethical problems and either identify, I'm sure Dr. Karnik and Michael are going to speak more about this whole issue of fairness and bias, but once you recognize that you may not be able to make it fair for all, of that you're reducing outcomes for some, to reach out to a cadre of ethics and regulatory experts to know that their assistance is needed before moving on. Or as Nigam Shah talks about, recognizing that in fact, if you may be potentially doing more harm than good, it may be time to throw out that particular algorithm and start over. And so that was the hope, was that there was at least some baseline framework people could use to screen their algorithms before it went too far.
What? Michael, did you have something to say?
Can I add a detail?
Yeah.
Sorry, I didn't want to interrupt you. Is that okay?
Yeah, sure.
And so, my perspective is someone who actually had to go through all of this to get to regulatory approval, now CMS reimbursement, etc. I think it was really important for various gatekeepers like the FDA that there is some ethical insight and it could be improved, and we are essentially developing the framework as we implement this in clinic, because AIs are diagnosing patients today, right? It's not future anymore, it's happening today. And so we need this sooner rather than later. But I think the good thing in response to Michelle is that indeed we now have gatekeepers that are very interested in this pathway and this framework that we sketched. Federal Trade Commission, FDA, Danton and I are members of a team who has members from FDA, FTC, soon CMS, all looking at this from, well, do we actually want to go ahead with this specific AI or this type of AI? So it is not just, in isolation that we're discussing this, it is actually impacting policy.
Yeah, that's really an interesting perspective, and I hadn't been aware that there were so many agencies interested. It does strike me that the remit of most of those agencies is pretty narrow and not necessarily commensurate with the scope of the kind of inquiry that we're talking about. FTC is there to prevent injury to competition and consumer harm, framed as anti-competitive harm, basically. And, FDA is there to assure safety and efficacy. And CMS, has a broader role, but it's hard to think of an example in which they've played this kind of gatekeeping role for a technology outside the narrow range of, the control that they have over Medicare and Medicaid coverage decisions. So I wonder whether you think that constellation of agencies is well enough positioned that we don't need another type of governance structure or not.
Oh, sorry, I'm not saying there's a solution right now. I'm saying there's a lot of interest and input to this, I would argue all of us are going to be affected by AI making diagnoses. And so we're all stakeholders. It's just, on different dimensions, you will have different representations. But you're right. I mean, the FTC is about consumer safety. And we can talk about why they're getting involved, but that's at the individual consumer level, the individual patient level. We're not even talking about population health, right? FDA so far doesn't look at that, even though they're interested. So there's a lot to be done. I'm just saying the interest is there, and gatekeepers are very interested. And I think one of the mechanisms is to either gatekeepers and hopefully not more gatekeepers, right? Because as a company, representing a company, more rules from different places is never ideal.
Thanks. This has been really interesting, the tensions between developing a framework that's going to be mostly voluntary and maybe partly regulatory versus a new set of regulatory frameworks, I think is going to be a very interesting question in terms of implementation of the framework that you've got. If you guys don't mind, I'd like to shift gears a little bit and talk about the sources of bias and some of those concerns that have already been raised. And I can see a lot of our folks asking questions are interested in those. I really wanted to unpack some of the different meanings of potential bias in AI. Sometimes bias is a function of decisions that superficially have nothing to do with, for example, race, like using cost as a proxy for healthcare, which very famously had a negative impact on Black populations and can lead to systematic discrimination against a group. Sometimes there are ways that biased or prejudicial decisions by clinicians or health systems lead to differences in outcomes that can be embedded in the data, like not listing developmentally delayed children for transplant means that those kids then die, which then is embedded in the data that you have worse outcome for those kids. And sometimes bias is more technically a limitation. For example, a lack of fit between training data and what it is applied to, or model overfitting, and some of these more technical definitions of bias that we see in a lot of the AI literature. So you see all of these different meanings of bias in the literature, ranging from these very technical things like overgeneralization to concerns about increasing or reifying health disparities. And of course, all these biases, sources of biases, even the technical ones, can be systematically problematic for those populations that are underrepresented in groups, leading to many technical limitations and problems. In other words, lack of diversity in data may contribute to bias attempts to apply models to populations in the absence of adequate data. Niraj, in your PhD discusses some ideas about how to address these problems. How would you think that these issues should be addressed? And should all these issues be addressed in the same way? That is, the more technical ones with some of the other kinds of problem sources of bias.
I mean, I think David, we're at sort of the earliest stages of contending with this in some ways, and what my team and I do is we sort of have we've been working in the space around addiction and substance misuse and predictive models there, and what we assume is that there is bias in our data. Like we don't just sort of go at it sort of post hoc now. We're kind of working with the premise that it is baked in, and that it is our job as we're doing the work to try to A, uncover that, to look at it, to scrutinize it, B, to trace its origins. So, going back in the pipeline, and figuring out where it came from. And then C, developing mitigation strategies for trying to address it. And I don't know if this is a lesson in terms of, thinking about this, but one of the things that we've done is kind of created a superstructure of groups to collaborate with and work with. So we have health disparities researchers, that are part of our team. I mean, I'm one of them, but you mentioned Marcela Nunez Smith. She's someone who is coming on board with us too, and the sizable group that she leads at Yale that works on health disparities. And we're trying to involve them early, but we also have community stakeholder groups, patient stakeholder groups, research ethics consultation. Majid Afshar, who's been leading a lot of this, who is one of the faculty who I've mentored, who just got an RR1, he really kind of went to all of the sources to try to bring all those broad stakeholders in, as Dr. Char was kind of talking about, but went much further than I think most people who work in analytics and algorithm development go. right? He took the further steps. And I think it's really that will help us uncover those different levels of bias. And I don't know that we can answer the question yet, whether the mitigation strategies are the same for all of those different levels. But I can tell you this, we have already found racial bias in our algorithms and in the way it works. And we know now that actually we can correlate to practice in the hospital. I mean, that's where it lies. So, I'm using this data to drive a shift in how we train our staff at the hospital to try and better address that piece of it, while Majid and the data scientists on our team are looking at ways to analytically control for this, within our algorithms and to, address it there. So it's going to take multiple strategies to address bias.
Danton, how do you think this notion and these concepts that were just introduced fit within your pipeline?
Oh, well, I agree with everything that Niranjan was saying. The goal with our pipeline was identification. So our framework can help to identify these problems, which are located, not inherently just in the predictive algorithm itself, but also in, as we were talking about, the underlying data that's used to train it, but also the way in which downstream decisions are made from it. And I think identification is a step towards problem solving, but obviously subsequently formulating and implementing solutions is going to require far more extensive involvement by ethicists and health disparities researchers, and a shift in views about the fiduciary relationship designers will have to patients and healthcare systems. I do think that Michael is probably better qualified to talk about this than I am, but I do think there's also the zero-sum problem that say Niranjan Shah or Steve Goodman have touched on, which is that attempts to try and correct these biases may either introduce biases of their own, or you make a series of compromises where though you can improve the outcomes for the previously identified disadvantaged group, you may, particularly since healthcare is by and large a zero-sum game, decrease the outcomes functioning on the previously more privileged groups that you had. And that's a very complex ethical issue to talk about.
Can I make it even more complicated? So a lot of the examples we've just been talking about are biases in the very technical sense, limitations in the data because they just don't have enough people from these groups, and then you wind up overgeneralizing, or the ways in which decisions get made at the level of algorithm design and all those sorts of things. But the point is they're seen as biases. That is, they don't, or even if the biases wind up getting reflect biases in clinical practice and get embedded in the data, the point is that there's still biases. If you make listing decisions on groups that would otherwise the data suggests do just as well, that's a problem that may not be detected by AI, but it might. But there's other kinds of problems that are not really biases in a straightforward sense, but they differentially negatively impact certain populations. And what I'm really thinking here is of the existence of the health wealth gradient that we know is a profound impact on the health of populations, as well as the health disparities that exist for minority groups that all reflect not biases, but actual real existing social determinants of health. The fact that the social circumstances in society that different populations face lead to actual differences in healthcare, and presumably anything that is system that's going to learn from outcomes will wind up reflecting the data, which will show that there are those very real differences, not biased differences, but very real differences, even though those differences are themselves a function of potentially inequality and injustice in society at large. How should predictive analytic models address these issues? Because when you're talking about bias, that seems more straightforward to fix the problem, but it's not as obvious that you're always going to be doing people who are being will be at the bottom of these things a favor by pretending that their outcomes are going to be better than they were. So if you're trying to predict who's going to benefit from aggressive radiation, patients who present for palliative radiation, you can guess that patients who are poor and patients who are Black are more likely to die within 6 months and hence won't benefit from radiation, and predictive analytics will predict that. But it's not clear that those populations are going to be benefited by giving them aggressive radiation when they're going to more likely die within 6 months and make their last 6 months miserable. How do we address those kinds of challenges and avoid the reification of the inequality that's there in our data because it's in our society?
Well, can I go ahead?
Yep.
You make a great point, but let's say that there is, so the AI that we made and it's now FDA approved is specifically geared towards solving for minorities getting fewer diabetic eye exams, which we already know from evidence, and that's different in your example, I think, has been proven to improve outcomes. So if you get your diabetic eye exam every year, you do better visually in a few years. That is, we can talk about that, but the problem is minorities are not getting them. And so you make an AI that is supposed, and hopefully, and it is, in fact, addressing that. You can build this in different things, and that's not biased. And that's why I'm so worried about building AIs from existing practice, where you freeze existing inequalities that exist, use that as training data, and then say, well, my AI does exactly what current practice is doing. Well, the whole point is to avoid it, like you said. And so I think part of it is still about the building and what data you use. And then part of it is understanding at a deeper level than just big data, which is not leading us where we should go. Instead of freezing what we currently do, which is biased and, well, it leads to disparities, right? Make it do better because we often have the knowledge to do better. We just cannot implement it in human physicians.
So what I'm hearing you say is that if the social determinant of health is access to healthcare, then
Yes.
potentially AI can help address that social determinant of health to actually improve that inequality. But of course,
there will be other examples. There are examples of that where we show that, and there's other examples where that is absolutely not the case. I'm not saying this in general, but in specific cases you can look at that.
Yeah. Other thoughts of anybody else?
I have a point of curiosity about this question, which is, to what extent is race being used in these models because we really believe there are racial differences in outcomes versus this is the most available proxy that we have in routinely collected clinical data for the things that we really think drive outcomes, like poverty or neighborhood or social support. I think the more I learn about this, and I'm very interested in Dr. Karnik's view, obviously, but the more I learn about it, the more I'm inclined to think that it's convenience rather than believing that once you were to control for structural racism, which comes through in other variables, that there's much of a race effect left over. And so I just want to throw out the provocative point that maybe we should stop modeling based on race and make more of an effort to purpose build electronic health records, hospital admin billing systems in ways that collect routine information about the fields we actually think drive clinical outcomes, which may be correlated with race, but are not race.
Well, I guess I think, first, I don't want to deny the impact, the very real impact that race has in the world. I mean, I think we only have to look to our brief history in recent months to kind of see those influences powerfully, right? So I think that to ignore race right now is we put ourselves hugely at risk of missing one of the key drivers of disparities. I will say that I think we can be much more nuanced in how we think about it, because I think race, if we were to take a sort of logical approach to it, right? Race has many dimensions, right? And if we think about it as a scientific object, right, there is self-ascribed race, like, the race that I, ascribe to myself is, I'm an Indian American born in the US, right? That is what I self-ascribe. There is societally, subscribed race. So like, what does society, put onto me just as I'm going about my life in the world? And that will vary depending on where I am, the institutions and the context I move through. And then, you know, we can get into biological and genetic race. And I think biological and genetic race is perhaps the least interesting right now in terms of its influences. I mean, very small influences in terms of certain, you know, enzymes and certain, you know, pathways that you know, influence medication, perhaps metabolism, things like that. But, you know, we clearly share more genetically than we differ in a lot of ways, and we've known that for a long time. But if we took it as a scientific object, then I think we could do that. But I think to abandon it right now is actually, you know, to me, counterintuitive when we see it, how much it determines it. And I can tell you, I mean, in our work, we found that, you know, we have a universal screening system, but it isn't a lock system in our hospital to screen for substance misuse. And so we try to get our nursing staff and the social work staff in the hospital to screen everyone in a structured manner as they're being admitted to our hospital. And we don't get everyone because, you know, humans are fallible. We didn't make it a required element as they're doing the admissions. And what we found in doing our machine learning work, our team discovered that white patients were much less likely to get screened with the screening questions than Black or Hispanic patients. And a lot of that goes to the stigma around substance misuse. And so there's a powerful set of, you know, issues here. And in this instance, we do believe that they revolve around race, right? That our staff believes that people who use substances are more likely to be Black or Hispanic, and therefore they ask the questions of the Black or Hispanics, and therefore they find the positives, right, amongst those populations, and therefore reify that model. And that has two problems to it, as you will, you know, Michelle, you'll largely get to, you know, with this. You will say, yes, you know, of course, we've reified an existing trope in our heads, which is what the machine learning could do. And secondly, we have neglected, actually, these other folks who are white from any type of screening that. By not asking them the question, we aren't picking up on their substance use, their alcohol use, their opioid use, all the things that are there, right? So it is a complicated issue. And I will say, I mean, Marcella and I and a couple of her team members are kind of working on trying to propose criteria to NIH to develop kind of race as a scientific, you know, concept along the lines that currently NIH uses sex as a biological variable. So every grant that is reviewed at NIH is asked to kind of look at, are they looking at sex and, you know, and gender in a scientific manner? Is there a justification for how they do that? And I think we need a parallel set of criteria for race to help us work through, you know, the question that you're pointing us towards.
Okay, I want to ask one last set of questions before we start looking at the questions that have been coming in from our audience. Obviously, to be able to use AI, you have to have data for training to take place. Some comes from electronic health records, some from commercial companies such as mobile health or wearables, some from health insurance companies with some of their data. Who, if anyone, should own the data from clinical encounters, since that's going to be one of the major sources of data? Should there be an expectation that dollars will flow back to patients when it's their data that really makes all of this possible? I'm going to start with Michelle on this question.
So it's a tough one because I think our moral intuitions are that we own our health data and that we should control it and we should benefit from its use. And the law doesn't match our moral intuitions on this matter. You know, the law is pretty clear that we have rights of control over our data to some extent, at least if it's identifiable, but we don't own it, and we really never have, whether it's in a research context or a non-research context. The law also expresses that perspective in ways that further undermine our autonomy, because to a large extent, at least in the private sector, legal rights are determined by contract or by quasi-contracts, by the end user license agreements that we mindlessly click on, by forms that we mindlessly sign in the doctor's office. And so it is a legal fiction that this is a meeting of the minds and a trade of mutual benefit, or at least that's reflective or deliberative. So to me, it's a problem that requires a resolution. I don't think the resolution ultimately will be individual patient ownership of data or consumer ownership of data. And I think that's probably just as well. I think there's enormous practical problems associated with effectuating an ownership regime, as well as with returning commercial benefits to the owners of those data, to individuals. But I think what we can do is think about what the underlying values are. And to me, they are autonomy and reciprocity. You know, on the autonomy front, the idea that we want to exercise meaningful control over uses to which our data are put, at least in situations where it involves risk to us, deserves to be honored in ways a lot more sophisticated than the ways we currently effectuate transfers of control over health information. So particularly given the presumption that once de-identified data are no longer worthy of moral consideration or control, I think that has to be examined. So I think there are much better ways that we can think about allowing individuals, or probably groups of individuals, to express preferences for data use and to exercise some oversight over that use. Again, if not individually as a patient, at least through representation on a data use committee or some other body that is directly involved in understanding and monitoring how our data are used. On the reciprocity front, I tend to think of this, again, not so much about how we return money to individuals, but how we return benefits to individuals and make sure that those who are giving data have reasonable access to whatever it is that comes out of the uses of those data that's socially good. I think there's a lot of ethics literature to build on in this domain in thinking about equitable distribution of burdens and benefits in the human subjects research context, for example, between higher income countries that contribute the capital and the know-how for research and lower income countries that disproportionately contribute research participants. And I find those frameworks to be useful. So I guess my question as a lawyer is, how do we think about enshrining some compact, some kind of social compact between the users and the innovators that benefit from health data and those that are contributing, sometimes against their will, those data to the innovation? And so I think there are lots of ways that we can use contract law more effectively to secure commitments on the part of the data users to return benefits in the form of making their innovations financially and physically accessible to the kinds of populations that have contributed data. I think there are ways to think about uses of audit and monitoring to make sure that there's actual compliance with those data. You know, I've always liked the Gorbachevian proverb, trust but verify. And I think when it comes to technology companies, that's the right regime to govern our oversight of these companies. You know, would public scorecards be helpful? There are lots of soft and hard law regulatory mechanisms that we can think about deploying with the goal of ensuring reciprocity. Because right now I think there is a great imbalance in terms of who's reaping the benefits of these innovations and who is contributing to them in terms of user information.
What about, Michelle, can I just ask a question? What about the intellectual property of the intermediary, of the clinician, right? Obviously the patients are very generous in donating samples and stuff, but obviously there's a great deal of training that goes into interpreting diagnostic specimens or making a diagnosis about depression or substance use disorders, and that then becomes inherent to the data set. Should there be any relationship or ownership on their part of the intellectual property that comprises the data set?
That's an interesting question, one I haven't thought about. You know, I'm inclined to say probably not, but I'm open to argument. What would be the argument for giving them a piece of the pie there? I assume you mean in a commercial way, that they would be entitled to some licensing fee or something like that.
Well, I mean, I know it led to some uproar, right? This is the Memorial Sloan Kettering Page AI business that certainly it rubbed a lot of clinicians the wrong way, that their work was being parlayed into a for-profit AI system without them seeing any potential benefit. I don't know that such a potential benefit if they're an employee of something. I mean, I defer to your expertise about all of that type of contractual relationship, but.
Well, yeah, I mean, it's really interesting. I guess I'm coming from a place where universities routinely exploit and benefit from the intellectual capital contributed by their faculty. And what makes this circumstance distinctive to me is not the role of the faculty or the clinicians, but the role of patients in it. So I guess I'm not immediately sympathetic to that concern.
Michael? Yeah.
Sorry, I'm eager to. So when I debate this in public, I often do a poll of the room, and everyone, if you ask them who owns the data, says the patient owns the data. So I agree that legally it's very clear they don't own the data, but everyone, and that's why Google and Ascension are having this lawsuit, right? This class action lawsuit. I would argue we need to start by at least making sure that we understand where the data is coming from, because right now no one is taking care of that. Or, well, we are, but most say, well, we'll just buy a bunch of data and we don't care about the patients or wherever it came from. As long as we can trace the data from its origin, either the physician, like Dan mentioned, or the patient, all the way to the AI, at least we can resolve this issue. But I feel very strongly that no, ultimately we'll see. Henrietta Lacks was a big example, right, where they have this eternal cell line, and people are still not happy with the way this was resolved. And so I think we need to resolve it in some way, and just saying, well, you don't own the data may not be enough, because everyone thinks they do, and you will have all these lawsuits. And as a company, that's somewhat problematic, if you see what I mean.
Thanks. Very interesting discussion. I'm going to start to turn to some of the questions that we've been getting. I have a couple of other questions that we may get back to, but let's see what some of the things we've heard. Leading AI companies and AI talent are located in select countries in the world. How do you think an adaptation of AI in medicine will impact the healthcare quality gap between rich and developing countries? One at a time.
Okay, so it's interesting because some I see going to countries with low regulatory oversight and get their AIs working there without knowing whether they're ethically sound. And some go to more rigorous regulatory agencies and do it in my view in a more ethically sound way. I'm conflicted because of a big conflict of interest here. I think our approach has been to develop the highest standard and then bring it out with, in this case, Orbis, which is this NGO that helps developing countries develop eye care, and then through them distribute it to the lower income countries, which I think you can go from the low income countries, develop it there, and then try to bring it to the high income countries, or the other way, and that's a choice that people make.
But you do think that it will eventually be able to be disseminated to those countries, even if they lack some of the infrastructure and some of the AI expertise?
Well, that's the whole point, is to bring it to everyone, right? And to diminish healthcare disparities. What is very ethically interesting is once you bring this AI is better than me as a retina specialist. So now you bring this very high diagnostic performance into an environment. What do you do with the patients who need to be treated? Because if the healthcare system is not good at diagnosing, it's probably not good at treating. And so now you suddenly have this ethical dilemma of, do I tell people a diagnosis where there's no one in the country to treat them, or do I just not bring the AI to that country? That's a different ethical dilemma. It's there. So we find some countries where at least the treatment capability is there. But we're not solving everything at the same time, though.
Okay. Anybody else?
I mean, it might be sorry.
No, go ahead.
No, I was just going to say it might be a moment to touch on the problems with the locked versus continuously learning AI, because David, you had talked about applying it in contexts that didn't have great infrastructures, and I know both can lead to ethically challenging outcomes. Michael, maybe you could say a little bit about that.
Yeah, I don't want to dominate the conversation, but so continuous learning means that every time you have a diagnosis, you compare it to the outcome and immediately update the AI, which if the outcome is not easy to determine by either a clinician or even waiting 10 years or taking a surrogate like the proxies with cost for outcome, right? Continuous can be challenging and ethically difficult. What is locked is nice because you know exactly what it does, and then you have it validated, what is going to happen to every patient beyond that. So I think that's what Dan wanted me to refer to. Dan?
Yeah, I think that's the gist of it.
Okay. And Niranjan, did you have something you wanted to add?
No, I mean, I was just going to reflect on sort of the topics that we've been discussing, really in this last two questions. Really, I think, I mean, we put our algorithms, our labs, with the University of Wisconsin-Madison, we put our algorithms into the public space, in the public domain, because, we're funded by the federal government to do this research, and just feel that that's the way to do it. We have no serious aspirations to do anything to monetize this. And I wonder, as the costs of doing this start to drop and more players enter this space, like, what is the reality behind sort of, monetizing this? And David, I think of this as akin to some of my colleagues who are psychologists who develop surveys and measures and patent them and copyright them. And I'm like, there are 300 measures out there right now for, like, family, therapy and family interaction. And if you copyright it, nobody uses it, right? And I think that's going to be similar to this. I mean, I would hope that the things that are put in the public domain just get used and, as a tool. And really the place to make, I think, the money in this game is really in the implementation side of this, like how to do this well, right? It's not the algorithm itself, I think, in the end, that's going to drive this. Because they're going to iterate, they're going to change, and we've seen this go awry in genetics. Like, as ethicists, we've watched, in the genetics field, as patents are placed on all kinds of genetic material, and it just gets harder and harder to function, as a researcher and a clinician in the space when you go too far down that road. So I think we would benefit from more of an open data model around this, and just saying, this is the space. The work is, and the value is in the implementation and making it work for people and for health systems.
Niranjan, can I push you a little bit on that and just ask? If you put it in the open space, so it's just out in the open space, and no one has ownership or accountability for it, what do you do when it's wrong?
Well, I mean, that's part of the learning curve of it, right? I mean, so ours is posted in a GitHub, and when we publish our papers, the GitHub link takes them there. People can use it, people can adapt it, people can learn from it. And if they do find an error, right, that I hope is part of our research and publishing process, right, is that we start to self-correct this, right? And people can do it very freely then, right? Rather than it being, hidden and locked, I mean, I think Michelle referred to at one point, it's kind of a black box, right? Like, that we don't know what's inside of some of these technologies. And that's exactly the point, right? That we often don't. So that's why we have to rely on this sort of disseminated intellectual, infrastructure to help us unpack it at times, right? Because none of us can do it alone. So yeah, I would hope that we could do it that way.
But are you willing to assume liability for, someone dies as a result, and who assumes liability, right? Is it the one using the AI who, I don't know. I don't want to use an AI like that as a physician.
It's a great question, and I don't know where the liability, sort of begins and ends with this, and perhaps Michelle has better ideas of those limits and how we define them.
Well, I think at this point, it's entirely unclear that product liability as a field traditionally has not recognized software as a locus of liability, except insofar as it's integrated with a physical product, like an autonomous vehicle or something like that. So it's just too early to tell. Fortunately, we haven't had many of these lawsuits percolate up yet, but it's not clear that product makers will have much liability, and that will mean that patients will look to the implementing clinicians and clinical organizations as the locus of liability. And, that really just argues for them to have a lot of understanding of what they're using and how they're using it, which, again, I have some skepticism about the ability of most people with clinical backgrounds to have the wherewithal or even time to do that. And the incentives for larger organizations like hospitals to exert a lot of effort in that space either.
So one of the questions sort of in a way builds on these points about the relationship between patients and physicians in the era of AI. They ask, as AI and healthcare progresses, will physicians and patients essentially have the same medical information at their fingertips? If so, might a physician's role in many cases be reduced to counseling patients on what AI synthesis of data suggests clinically, for example, a predisposition for certain types of cancer?
Yeah, I don't know as a descriptive matter how accurate that is. I guess I'm probably not the best placed person on the panel to answer whether eventually the more useful systems will be publicly accessible or will be instead inbuilt into other decision support systems, in commercial organizations that pay for it. It seems to me there will always be a role for physicians or other healthcare providers in helping patients interpret and contextualize the predictions of models. And by contextualize, again, I'm referring back to the notion that when we make clinical decisions, we would hope that there are some values being brought to bear along with the prospects of success, that patients are guided through a process of considering what their lives will look like if it's not successful, or what the alternatives would be and how those alternatives might fit with other life goals or economic solvency and so forth. So perhaps it would be ultimately more of a navigator than a technician, but it's hard to imagine a time when physicians aren't figuratively, if not literally, holding patients' hands through very difficult decisions about treatment.
Dan, what do you think?
I think that that's true. I think that there is going to be a long period of time where we need a human in the loop, as Nigam Shah would say, to be an intercessor with this data. I also think, Michael and I have had a number of these conversations offline, as well as with Chris Feutner, our other author on the paper, about these particular exact issues. If it's not enough to just try and run simulations based on the data sets that you build it from, but in fact, you're going to have to do studies with pre-specified endpoints that actually show that the AI is doing good and doing what you hope it would do. And in many ways, I think that's what we in medicine have to contribute to do better than say how AI has performed in the social media space, is to actually demonstrate that the benefits that we would hope it would engender into the delivery of healthcare, that it actually does engender into the delivery of healthcare.
And David, I think the physician, the providers become more important in this, actually. I think that their value rises in terms of making sense of a lot of this, because I think that it isn't a shortage of data right now. I mean, we are awash in data, right? That is actually the difficulty here. The challenge is not actually more data. The challenge is actually a data reduction challenge, right? Which is, I think, a lot of what AI is trying to do, right? I mean, the material that we're looking at in terms of our algorithms is enormous in volume, but it's all available to the providers, right? If a provider sat there with a single patient's record and looked at all of their values, all of their notes, all instances of mentioning this, they might be able to come up with something akin to what our AI work does, right? But it would take them an obscene amount of time. It's unfeasible, right? And it's unfeasible to do it in a complex way that it does it. What the provider becomes in this is someone who can interpret this and weigh things, right, in an important way. And this is where we go back to that discussion about bias, right? When does this algorithm spit out something that doesn't make sense, that doesn't fit? Because it's going to hit those points, right? It is not an infallible tool, right? And so I think that's part of why we are encouraging folks to bring these, stakeholders and health disparities researchers to the fore in the front, so that we can actually assess those incongruities early, right? Let's not have that happening at the patient's bedside. Let's have that happen in the lab early on, so that we can, do that. But to some extent, I think the providers are going to have to do this constantly, especially when we have a multiplicity of tools that are coming and spitting out different recommendations and different ideas, right? And how you understand all of that data that's flowing behind it, and the data reduction process is going to be the role of the provider, I think.
Well, I look at it differently, because maybe, well, I agree with most of what you say, but this specific AI that is FDA approved is better than me. So if I look at a patient, which I don't, because I let the patient be seen somewhere else where they actually are rather than come to me, if I disagree with the AI, I'm probably more wrong than right. And so I cannot say, hey, something is off with this AI, because I'm worse than AI. And so I think there will be a shift, like Michelle mentioned and David mentioned, of more consultation type stuff and less diagnostic stuff. But again, what do I do if I disagree with the AI? There's no role for me anymore, right? And explaining the result of the AI, but I'm not going to overrule it in most cases.
I do worry that there's a lot of emphasis on AI for something that's actually happens in other kinds of situations, right? We live in a world where there are pathways, where formulary decisions are made.
Yes.
Patients, it often seems like physicians are pretty much autonomous, exercise their judgment and do what they want. But everybody's aware that there are all kinds of constraints on what physicians do that are opaque from the patient's perspective. So will this just become one of those, or will patients have access to this in a way they don't to the pathways or the formulary decisions that may be driving the healthcare decisions of their clinician?
But Michael, I understand what you're saying, that the AI tool is better than you at this particular instance, right?
Yes.
But what happens when something new arrives on the scene that the AI hadn't accounted for, right? What happens when, you know, our AI for flu diagnosis hits COVID-19, right? It's a new moment, right? And I don't think that the AI is really, you know, capable of making that leap necessarily, right? That adjustment that has to happen in that moment, right? And that's where the human has to be there to kind of sense, okay, something is changed here, right? There's a new thing happening that now needs to be reassessed, right? And I think when we have a proliferation of these tools, it's going to be even more important to have that human that sits there and can kind of globally look at this. And we might imagine that there's some uber AI, you know, a doctor like on Star Trek, you know, that can materialize and function that way. I don't think we're very close to that type of, you know, level of AI at this point. So
sorry, I meant the same thing as you just said. Sorry, my whole point was the doctor integrates what the patient tells them as well as what all the AIs are telling them.
I mean, we've had for a long time. I'll give you a great example. I remember when I was in training, you know, when we would get the EKGs, right? And the EKG machine would spit out the interpretation, right? You know, normal sinus rhythm or this. And I remember the attending cardiologist would hand you the ones that, you know, it reads as a normal EKG, right? But there is something aberrant in there, right? And reading EKGs, I think, is like an art form, really. I mean, you know, there's a certain science to it too, right? But a good cardiologist, right, and you know, can just look at the waveforms, right, and they know what is normal and what is not, right, and they can do it at a level that the machine is good. The machine is actually really good when it hits normal things in a normal fashion. It's when it hits things that are, you know, when you get a case of situs inversus, right, and it doesn't know that this human is like a mirror image of themselves, right, that it kind of causes it to kind of fall apart. It can't pick that up well, right? So I think that's where the provider comes in, is to handle, I mean, my colleague Majid Afshar calls it, you know, the art of data science. There's a certain art form to this, as well as the science of data science, right?
No, I agree with you.
So one question, switching gears a little bit, since if AI is going to be used to diagnose symptoms, how do we protect the data privacy of the patient while using the data? So there's a question being raised about the data and the privacy issues that this raises. Especially, we talk a lot about de-identification, but of course, AI represents in some ways a threat to the very idea of de-identification. Michelle, what are your thoughts about de-identification and privacy? And is AI a threat to it, or how should we be thinking about this?
Well, I think there is a threat to it, but I'm not sure that it comes from AI. I think it just comes from the nature of the advancement of computing science over the last decade or so, that we are now in a place where de-identification is a temporary state for the most part. And that is only going to become more and more true as the sources of other data through which we can triangulate with putatively de-identified data, those sources increase and the methods become refined. So it's becoming increasingly feasible, and I think that completely destabilizes our existing oversight system for health information privacy, which is all predicated on the assumption that once de-identified data are always de-identified, and that state of de-identification is synonymous with no risk, no threat, and even no dignitary interest in retaining control over data. I think that requires a fundamental reexamination again, I don't think this is because of AI. I think we would be here in the same place even without AI. It's simply that some high profile uses of medical data have brought it to people's attention in a way that it hasn't before. But it's a real issue. And right now, no one that I know of who has any degree of regulatory authority is tackling it. There's not really a recognition that our regime needs to change. So I think there has to be some evolution in the regulatory regime. I think there also has to be some evolution in people's expectations. That I think there's still a mismatch between, to your point, Dr. Abramoff, between what the public understands to be the case regarding their data and what the real world is. And, even outside the medical realm, the uses to which people's data are being put, the extent to which individuals sitting in cubes have knowledge of us and our habits is still a big unknown for most people. So there's going to have to be a reckoning with that, an understanding of where we are already. And I think even more importantly, a deliberation about what kind of trades we're willing to make. Because as I've written before, almost everything that we do online right now involves trading information for goods and services of value that are provided to us at free or no cost. And that's a bargain worth considering because it offers a huge upside, but it ought to be entered into deliberatively and thoughtfully. And I think at the moment it just isn't.
I think I'd also just add to what Michelle's saying is that there also is, and I know, David, you've spoken about this, about some of your work with larger genomic stuff like all of us, that there is definitely a trade-off to be had of an overly restrictive pursuit of an ethical ideal like privacy, but also then limiting access to a very valuable resource, and that compromise will need to be struck at a much broader level than the individual patient now. And I think that's very, very challenging. Certainly, we have seen ethics groups become stakeholders themselves that influence things. There was a high-profile article recently in the Times about the fetal tissue ethics oversight at NIH, limiting the amount of research funding that was occurring within that space. And I think that that's a challenge that we'll have to address.
Okay, we have just about time for one last question briefly. Is it unethical that medical schools aren't teaching about AI to medical students, given it's going to become part of standard practice?
I mean, I think there are 20 things that we could say it's a travesty or not taught in medical schools. Most physicians don't even understand the Affordable Care Act. As a health services researcher, I would start there. But yes, of course, physicians should know more about this. I just think it's a hard thing to integrate into the curriculum at this particular moment in time because there's just a lack of concreteness about what it is that they will encounter once they are out in the world. When we think about where this field will be in even just 5 years, it's difficult. But I would say certainly it should be part of continuing medical education, if not medical school.
Yeah, I see what you mean, but we are so much behind with pharma, with drug studies, that medical students, when I teach them, they don't know what a pre-registered study is. They don't know essentially why a randomized clinical trial is so important. And so I think it starts with that, and we're running behind on pharma. So let's at least start in time for AI and all these AIs coming. And how do you value the studies showing their safety or not, right? I mean, we need to start somewhere. I see they're too busy, but I think it's important.
I think we're going to see it come into the medical curriculum, pretty rapidly. I think the interests of the students themselves is driving in this direction. And so a subset of them are probably going to, start to pull this in and bring it in there. And we're seeing some of that already. So.
And if I may, I actually think the bigger problem is not that we're not teaching doctors about AI, but that we aren't teaching those who are designing AI ethics. And as you know, David, this has been such a huge thrust here at Stanford, with recognition that we're pumping out the world's next generation of data scientists with not very much reflection about some of the hard choices that they're going to have to make. And with the field in what I would consider to be its ethical adolescence, I think there's a much greater need for ethics in that field than there ever has been before.
Michelle, with that, it would be great if the technology workforce were more diverse and representative of the populations that these tools then start to impact. I think it would enrich the conversations and really support the ethical development of tools by having those stakeholders sort of in that pipeline, like there to wrangle with and develop these things, alongside the folks that are in there right now.
Well, thanks very much. We're out of time. I do want to just say that for information, in addition to the issue of AJOB this month dealing with this issue, there is also an issue of the AMA Journal of Ethics that had an issue on AI ethics and a podcast dealing with that. And there are links to that in the chat. So thank you to all of our panelists. This was a great conversation. And thank you to all of you who attended this webinar.
Fun. Thanks so much.
Thank you.
Thank you, everyone.
I also just want to thank our third co-author, Chris Feutner, who wasn't
Yes,
able,
great point.
who was obviously immensely fundamental to us writing this paper.
At the smallest role. Thanks so much, everyone.
Thank you.
Thank you.